Welcome to session 3 of prostate cancer screening in primary care echo. This is our second cohort. Today we will be discussing who falls outside of the screening criteria and when is it time to stop screening. If you have a question, please do come off mute, raise your hand, or simply put it in the chat. We want these to be interactive sessions. We are not intending for you to listen today only, so please do engage in discussion. Once we get through all of the welcome and announcements, Miss Molly Black will go through the introductions and program objectives, as well as a recap from session 2. And then we'll have our clinical presentation by Dr. Wolf and time for Q&A. And then we will go into our case presentation from Roots Community Health Center, and we'll have ample time for discussion there. And then we will do our survey and wrap up. And with that, I will turn it over to Miss Molly.
Well, happy Friday, everyone, or whatever day of the week it is as you are listening to the replay. You're seeing our amazing hub team. Dr. Naime isn't able to be with us today, but you will see him in the next session. Dr. Tosayan and Dr. Wolf are here. You're going to hear from them today, and we're going to get started. Just a reminder. The goal is to enhance understanding, communication, and implementation of appropriate prostate cancer screening and referral practices within primary care. Really looking at how we communicate with patients, and what data we look at, when to refer, and breaking down some of the barriers and knowledge there. So by the end of this ECHO program, and so you can get the replays. If you've missed the other sessions where we've talked about some of these topics, they're all on our ECHO website, and we'll make sure you have that link. But by the end of this ECHO program, we want participants to have the knowledge to initiate and discontinue prostate cancer screening at clinically appropriate times, facilitate informed decision-making conversations with patients at the onset of screening, reduce potential harms and limit overdiagnosis through evidence-based screening practices, and make timely and appropriate referrals to urology or specialty care following PSA test results. And I was really reminded yesterday in a different conversation on prostate cancer screening how different the landscape is in harms and benefits than it was even a few years ago. So I'm so glad you all are coming and engaging with our subject matter experts, because you are going to be ahead of the curve in this very quickly evolving space. Okay, now I get to turn it over to Dr. Wolf, I believe. Oh, recap. No. I get to do a recap. So if you missed this, we'll make sure you get the recording. We talked a lot about when to start. What is the optional age to start by risk groups? Average risk men, and Dr. Wolf went over different clinical, studies and the data there for average risk, high risk men. And then, this is a big point that I'm sure you all know, but the risk stratification is crucial in figuring out what's the optimal age to start for that particular patient that is sitting right in front of you. And PSA levels really should be interpreted with caution. Repeat testing is essential. Want to hone in on that statement, just to get it in there, because that is one of the ways we decrease harm is by getting that PSA changes for a variety of reasons, and so making sure a repeat test is done, so that you don't push over that first domino too soon on the referral process and next steps. So shared decision making is essential, that informed decision making. And we heard on the survey and feedback, people really liked your shared decision making light, Dr. Wolf. And so if you missed the description of shared decision making light, highly recommend you listen to that replay. Next slide. And Dr. Wolf has no disclosures. Take it away, Dr. Wolf.
Okay. Great. Are we able to hear me? Okay, good. So today we're going to turn our attention away from when to start screening to arguably a harder question of when to stop screening and who should not be screened. And and those questions overlap, of course. So we're going to start with what the evidence tells us from the clinical trials. And we've talked about these clinical trials, so I'm not going to review the trials again in length, but the European randomized study of prostate cancer was the largest clinical trial we've had of prostate cancer screening, which did show a benefit to screening, as we've talked about. And that trial was actually more like a conglomeration of 7 trials because there were 7 European countries and they did have different screening criteria. So 5 of the countries screened men up to age 74 and 2 up to age basically 71. All of the countries had in common that they enrolled men 55 to 69. And because that all of the countries enrolled men in that age group, they considered this the core age group for studying the overall results. But a number of the countries did screen men into older ages, and even those who screened men 55 to 69, they had another 1 to 2 screens every 2 to 4 years. So what we know is that men were screened at least to age 69, and a number of men were screened up into their early 70s, basically up into age 74. And that study overall did show a screening benefit. So we have some evidence that screening up into the 70s is beneficial. The Göteborg trial, which was a Swedish trial, and overlapped actually with the European study, the oldest men screened in that study were 70 to 71. So again, excellent evidence that screening works up to that age. The CAP trial, which was the British trial, also did show a modest screening benefit. The oldest screening age there was 69. So very solid. We know up to 69 is beneficial. And there is some evidence that screening into the 70s is beneficial, evidence from clinical trials. Now, next slide, please. Now, I just wanted to show you the survival curves between the control group and the screen group in the 2 big studies, the European randomized study and the Göteborg trial. And what I wanted to point out here was that the mortality benefit pretty much consistently emerges at right around 10 years. You can see that the survival benefit in the screening arm started to diverge from the control group at about 10 years. And so what that tells us is that overall, if you're looking at a man in front of you, they need to have a 10-year life expectancy at least if you're going to see a screening benefit in terms of mortality reduction from prostate cancer. So that's an important takeaway, 10 years minimum. So next slide, please. So this was an interesting, actually, a cohort study that was a spin-off of the European randomized trial looking at the Netherlands. 7,000 Dutch men who did participate in the European randomized trial were followed. These were men who were screened between 70 and 74 years of age for the last time. They had had an average of 1 to 3 screens in the trial. Screened 70 to 74, and then followed for about 16 years on average. So their chance of dying from prostate cancer by the age of 85 was well under 1% if their last PSA was 3 or less. That is on the right side of that figure on the right. That's the green arm. So you can see almost 0%. But well less under 1% of those folks who had a PSA less than 3 between the ages of 70 and 74 died by the age of 85 of prostate cancer. So that's a pretty low risk of dying. Their risk increased to 2% if their PSA was between 3 and 6.5 at the age of 70 to 74. That is the orange line there. And then their risk jumps to 7% risk of dying from prostate cancer by age 85 if their PSA was greater than 6.5 at the age of 70 to 74. That's the red line. So, and then if they'd ever had a benign biopsy during the course of the study, their risk of dying from prostate cancer was low. It was 1 to 1.5%. That's the blue and purple lines on the right. And so, this is fairly illuminating. Next slide, please. So I would say that it is safe to stop at age 70 if the PSA is under 3. And that's about 75% of men. So that's one important takeaway. But what about the other 25% who have a PSA of 3 or greater? Still, their risk is higher in terms of risk of developing and dying from prostate cancer. So then we have to look at, based on the randomized trials showing a mortality benefit after 10 years of follow-up, screening men over 70 who have more than a 10-year life expectancy does make some sense in that they could still stand to benefit. And keep in mind that this is also the age group who are at higher risk of developing prostate cancer. So this is a tough one. Their risk is rising still at the age of 70. But we also have to worry about overdiagnosis and overtreatment. And we're talking about treating older men with the risks of side effects of treatment perhaps greater in older men. So 10-year life expectancy or more is a good rule of thumb. So then the question becomes, who has more than a 10-year life expectancy? Well, a man in average health at age 77 has about a 10-year life expectancy. And men in the best of health have about a 10-year life expectancy at age 80. But when you're looking at a man in front of you, that can be hard to determine who's average. We have an average child, our families have an average number of children of 1.9, but no one has 1.9 children. So it's really hard to determine what is exactly average. So what can we do to refine our estimates of life expectancy? Next slide. One thing we can do is we could use life expectancy calculators. And I'm putting in a little plug here for the ePrognosis calculator out of the University of California, San Francisco. I have no stake in that game, but it's validated. It's fairly easy to use. You have to ask you have to know some clinical information about your patients and some functional information about your patients in terms of their ability to do ADLs and instrumental ADLs, like shopping and doing their finances and whatnot. So you have to know something about your patients, or at least take educated guesses. But if you do that, it can provide some useful information at the individual patient level. And I'm going to give you an example. Next slide. So using the ePrognosis life expectancy calculator, you have a man who's a 73-year-old former smoker who considers himself, and you consider him in pretty good overall health. His BMI is over 25. He has stable COPD, hasn't been admitted for it in the last year, but his exercise tolerance is limited. He can only do about a block or two of walking. He no longer does heavy housework, but is otherwise independent. Well, if you put that all into this ePrognosis life expectancy calculator, what you get in terms of the risk of 10-year mortality there, you can see 52 to 58% risk. So more than 50%. His life expectancy is not more than 10 years. It's 9 to 10. This is a man who he's doing pretty well. You would not want to be screening him for prostate cancer. So what do? That's a question we can talk about perhaps in the discussion. How do you stop screening men, and how do you tell them they're going to die too soon? Well, I never say you're going to drop dead, so don't worry about it and cancel all your subscriptions. I don't do that. I say, you know what? Congratulations. You are very unlikely to die from prostate cancer. We're going to focus on other things. And we can talk more about that in the discussion afterwards. Next slide. Another way you can determine if we should not offer screening or stop screening is to think about frailty. If your patient has any degree of frailty, it is time to stop screening for prostate cancer. And this is something called the clinical frailty scale, which I find useful because it's just very easy to understand and it's intuitive. And if they have any degree of frailty, which is basically a clinical frailty scale level of 4 or higher, they don't call that frail, they call it vulnerable. But these are folks who are slowing down, whose overall just endurance is reduced. They complain of being tired during the day. They don't exercise. They might walk, because they need to walk, but not. They don't go out and walk for exercise. So if they're not exercising and they're slowing down, their life expectancy at age 70 is well under 50%, their 10-year life expectancy. And so frailty and anything worse than that, they're using a walker, they depend on other people for transportation or finances or their meds. Anybody in that category, don't think about screening for prostate cancer. And that's important because I think right now we, meaning the primary care clinician population, tend to be screening a lot of men who we shouldn't be screening. And so think about frailty. Next slide. So I put this out there. I haven't seen anything on this. So but listen, we're all using AI every day probably. And so what about its role in life expectancy calculation? So I've been fiddling around with it. And I looked at the references they used, and I think it could be pretty good. And I think it can complement our clinical judgment. I wouldn't just rely on ChatGPT. I would look at the patient in front of you. But I put this in there. What is the life expectancy of a 72-year-old man with moderately well-controlled type 2 diabetes, say an A1C of 7.5, well-controlled hypertension, well-controlled hyperlipidemia, and a BMI of 36, so obesity class 2? Well, that patient has a life expectancy of 9 to 10 years, and that wouldn't meet the 10-plus year life expectancy. We would not want to screen this guy who's doing pretty well. I mean, when I have a patient who's 72 and has pretty well controlled diabetes, hypertension, I'm pretty happy. I want to work on his weight, but that weight and that diabetes, those are the main drivers of his reduced life expectancy. And so just think about maybe toying around with ChatGPT, or I use Open Evidence, this could be a nice adjunct to your clinical judgment and the ePrognosis calculator, or the ePrognosis calculator. Now, what do the guidelines say? The U.S. Preventive Services Task Force in 2021 gave a D recommendation to screening over the age of 70 or 70 plus. They went very, very strictly by the eligibility criteria for the core group of the European randomized trial, which was 55 to 69. Now, personally, I feel like they are leaving out a good chunk of folks between the ages of 70 and 75 who are in excellent health, who also have a rising risk of prostate cancer, who could benefit from screening. But this is what they say: recommend against screening 70 plus. The American Cancer Society, whose update is underway, so this is from 2011, says stop screening if the life expectancy is under 10 years. The American Urologic Association, which has a more recent guideline, says stop if the life expectancy is less than 10 years. The National Comprehensive Cancer Network this year came out with an updated guideline, which says screen up to age 75, assuming they have a 10 plus life expectancy, but discontinue screening if life expectancy is under 10 years. They also say continue screening beyond age 75 should be performed only with caution in very healthy patients with little to no comorbidity, especially if they have never undergone PSA testing or have increasing PSA levels. Now, I think that makes a lot of sense, that caveat there. It is not strongly evidence-based, I will say. But the point is that these are folks who perhaps have never been tested, so you're harvesting people who might be harboring a clinically significant prostate cancer that hadn't been picked up earlier, but only if they're expected to live long enough to benefit from that early detection. So I think that last little bullet makes some sense. Next slide, please. So take home points from this discussion. I feel it is okay to stop at age 70 if you don't want to individualize. If you just, you don't have time, you don't want to think about this, well, you have a guideline telling you don't stop, don't screen at age 70 or older. So you can do that. Now, personally, I think it makes sense to have a more nuanced approach to potentially get great benefit from people in their early 70s who would benefit. You can safely stop at age 70 if the PSA is less than 3. As you recall, those folks are very unlikely to die of prostate cancer in the foreseeable future. I'd recommend stopping when the life expectancy is under 10 years. You can use a calculator like ePrognosis, or you can use AI to refine your estimate. I would say that any frailty, any degree of frailty precludes screening. And like the NCCN says, screening men over 75 should be limited to men who are the very healthiest. And I think those are all I wanted to say, and I wanted to open it up for a discussion.
Well, Dr. Wook, we've got one question to start us off here in the chat. Are there clinical trials similar to this for other races? For example, Black African American men, since they have higher rates of prostate cancer. So, the slides you were presenting on, those initial when to stop.
Right. And that's a big weakness of all of our literature on prostate cancer, because the only large trial from the United States was terribly flawed. I discussed it in our first echo of this session series. And that trial didn't show a screening benefit. But remember, there was so much contamination, like the control arm was all heavily screened and whatnot. So there were and people didn't get biopsies. So we don't have answers. Now, having said that, we have enough data that we are developing modeling for prostate cancer that would be relevant to the United States, in that the models will look specifically at African American men and white men and the whole population. So we're going to be hopefully having more modeling evidence to help support when to stop screening, that is to be announced. I don't have those results, but we should have those. We have modeling as to when to start screening from prior, from the U.S. Preventive Services Task Force modeling, and even though they didn't abide by this in their recommendation, it did look like starting screening for African American men 3 to 7 years before white men, which was why I think starting 5 years earlier makes sense. It conferred a comparable benefit. So that starting screening, different issue than stopping. So to answer your question, no, we don't have it, and it's a problem, because the European not enough Black men to analyze separately.
I'm curious with all of our participants. So, question for you all: do you use these, the calculators for, the assessment of longevity and frailty? Are there tools you use for other disease states that are helpful? Is everybody going to ChatGPT? Eyeballing it, Dr. Bittner-Fagan.
I have not used ChatGPT, although now I might. And I just, for kicks, was multitasking, and I used the tool on my dad to see what it would say. Don't tell him. It's been a while, but I had asked some of my geriatrician colleagues about these tools. I would say it was about 5 years ago. And they said they're not very good. we don't really buy any of the, how many years do you have left type of tools. So I was not really using these. In the back of my mind, they weren't very good. You know what I mean? So I wasn't, I haven't been, but I plan to revisit. That one was really easy. The UC, was it UCSF,
Yeah.
courses.
Yeah. If
Um,
you just Google e-prognosis, it'll come
Yeah,
up.
I put it in the chat, Dr. Wolf,
Yeah.
for
Oh, good.
everybody.
Yeah. Yeah.
and most of that information you have, and it allows for unknowns, so you can kind of breeze through that pretty quickly, and at least, um, and it doesn't have to be perfect. And kind of thinking about it. I mean, part of the challenge of continuing or not continuing is do you feel like you did due diligence either way, and having something that is the best you know available evidence to quantify that, I think is useful.
Right, right. No, that's a great point. And I'll mention that with the e-prognosis, they do have several cancer specific calculators, but it's only breast and colon. So they don't have a prostate one. And the nice thing about e-prognosis is that all of the stuff on there has been validated. It's not just somebody's great idea that seems like it might work but doesn't really. So they're good. AI, I have to say, you know, it's kind of a new frontier. But if I looked at the references they used to come up with that specific example I came up with, and it all looked reasonable. They weren't fake references, for example, which is a issue with AI. Sometimes the references don't even exist, and it's like, what the heck?
Yeah.
Uh, so that's I was taking it with a grain of salt. It's just that it can be hard for us to estimate. I think we tend to overestimate people, and we don't really think that their frailty makes a big difference. They're still doing pretty well, but boy, I'm always struck by how bad frailty is in terms of survival, just as an example. And yeah, play around with these. I think you'll find it interesting and useful.
Dr. Vikram Fagan, you've got your hand up.
Only if nobody else wanted to comment on
You go. I'll get everybody else talking.
No. Um, so first I just have to say this for the comedic benefit of everyone. I once was trying to do a search using Chat GPT for a talk, and in full disclosure, part of the talk was like, how good is this? Like, what are the references like? And it was about using testosterone in healthy men. And and I said to it, give me, evidence-based answers, thought leaders, and show me your references. But one of the things it referenced was a website called More Plates, More Dates. Pretty sure that's not going to fall under the criteria of evidence-based. So yeah, check the references on ChatGPT.
Yeah.
If nothing else, you'll get a chuckle. Somebody brought up, how these conversations might be different with African American and Black and Brown men. And in general, I would love to see some tools and guides, you know, like I've seen sort of here's, that HRQ picture of like of this many men, here's how many will get cancer, here's how many will die. I would love to have some African American men specific tools because I feel like it's a whole different ball game. Not only is it, different in terms of the numbers, and I don't want to be showing them numbers and citing numbers that are white men, but it's also an emotionally different game, right? Because that community's been, at least where I'm from in Delaware, we have a pretty active community that's kind of getting the word out. So as opposed to, I feel like a lot of white men who are like, I heard you don't have to do that anymore. Woohoo, not, these men I feel like are like, almost feeling like you have, the medical group, you guys haven't been doing this and you've been doing us a disservice by not. Do you know what I mean? So it's just a very different conversation. And I'm just going to put that plug out there, Molly, and everybody. Like, I would love to see more patient facing, informed decision making, facilitating tools that are very specific to African American men.
Yeah, and I think you bring up a good point, and also the question about like when to stop, both when to start and when to stop, because the data, because we don't have the modeling, studies yet, it's hard to say, well, here's why I think you're good to stop. We can focus on the diabetes, we can focus on COPD, like whatever it is. It's so hard. I mean, I can, in your mind to be like, well, I don't know if that actually plays out for the patient that's in front of me.
Yeah,
I think the 10-year life expectancy is probably Dr. Wolf would like that's probably, but it's so different, and comorbidities show up and have a different impact on life expectancy.
that's right.
Um, so
And
yeah, I think, so Luke, write that down too.
I think the key
For
is,
specific, and it also I think it might be by comorbidity,
yeah,
as well. Like we could have some specific, you know, things around, because that also plays a role
yeah.
in it.
I think the key when we're having these conversations, and we've decided that it's time to stop, is to point out that um, that the reason we're stopping is that we feel that you're at low risk for dying from prostate cancer, and your risk of us doing harm to you is getting higher and higher. So we could actually, so we're actually more likely to harm you at this point than we are to benefit you by continuing to screen. And the other point, especially with African American men, is we need to shift the whole curve earlier, right? We shouldn't be, yeah, so often we're starting screening, or we notice that somebody hasn't been screened in 12 years at the age of 73. So we really need to be having these conversations at 45 for Black men and 50 for white men, and getting them on the bandwagon early. And then it's a much easier conversation towards the end to say, listen, we've been screening all this time. It's now a fine time to stop. Um, and so good. I know we're out of time, I think.
We're kind of out of time. One here, are there other AI tools that are used besides ChatGPT? You mentioned one, Dr. Wolf. Evidence something?
Oh, open evidence. I don't know if you guys are using this, but it's an AI tool that's really specifically geared towards medicine, and it is excellent. Now, again, when it comes to life expectancy, I have not been exploring these tools in any depth, so take it with a grain of salt and check the references on there. But uh, um, uh, open evidence in general for health related medical questions, I have found just superb, and have been using it a lot. So now there are probably a dozen others that I'm not aware of.
Yeah, and I think open evidence is one, correct me, Dr. Johnson, but that Dr. Hotz brought up at one point that he was using. So that's good to know. And I actually, while I was multitasking and Googling to get that link for y'all, I saw like the AMA has a whole page on tools where you can get CME credit as well for, learning about the tools and how to best use them. So that's another option to go to the AMA or your, AFP and others. Probably have some good guidance and you can get credit as well, which is always a bonus.
And
Okay. Thank
well,
you, Mindy, for putting this up. Mindy is a phenomenal, tactful timekeeper. Thank you, thank you. I'm so excited that we have a case from Roots. Roots was part of our first cohort of this echo and has come back. And I'm looking to see, is Mary not on? Is our Roots crew here? I'm not seeing our Roots crew on the participants.
I was looking as well. Uh, I don't,
Well,
I don't,
let's
mm.
Hey, let's pivot. Okay, so I'll start with this question, and then if we don't get any responses, I've got other questions to get us started on some cases. So, anyone have in the last few weeks someone who they needed to have a conversation with to discontinue screening? Last
or,
few
or
weeks, months,
last year or two.
yeah, or last year or two. What's just think about the last time you're like, ooh, maybe we should discontinue this patient. And maybe you punted that conversation until after this echo. Um,
I recently had a conversation with a patient. And another thing I would change is I was doing it more like 75 was my kind of trigger to say, like, let's have the conversation about stopping. Um, I don't remember exactly how old the patient was, but he was older than 75. And he really wanted to continue screening. And in the end, I was like, okay, like it's fine.
Yeah.
And I think that part of it is, and I'm getting better at it myself, but I think, to have conversations about cessation of cancer screening in some ways are to have conversations about mortality. Um,
Yeah, I agree. And you know what? This is an informed decision, and yeah, as long as they know why we're recommending that we stop, um, if they want to keep screening, I have not said you cannot be screened. You know, I'm not going to do that. But I do it with trepidation in some patients. Uh, and you know, I'll give you an example, though this is a little bit of a weird one. I had a patient who was in his upper 70s, and I thought, you know what, he had taken a couple of falls, and I thought, he's getting into that elderly cohort now. However, his falls were in the context of still running like 10 miles. So his functional capacity was unbelievable. And so he had PSA anxiety, and I did talk to him about it would be fine to stop screening now, but he didn't want to. And we screened, and he ended up having an elevated PSA. Bottom line is he did have a Gleason 7 cancer and was treated with radiation. And then within a year of his radiation treatment, probably less than that, started having significant problems with word finding and has been diagnosed with primary progressive aphasia. And it's
wow.
progressing quite rapidly and now having major cognitive problems. So now, could I have predicted that? No. And so I don't think I did him any favors to treat his prostate cancer. I think he would strongly disagree, or, that if he could articulate that now, which I don't think he can, he would feel like we saved his life. But, I think he will be dead within 10 years. So an example of, I'm not sure what the take home there is, except that I had reluctance based on his falling, and maybe that was somehow the beginning of some cognitive issue or something. I don't know. But in any event, I was concerned about screening him. He was, say, 76 or so, 77. And, but he was still, physically functioning in great shape. But then, all hell broke loose.
Do,
So, um, yeah.
do you talk about one of the things that really popped up in one of the things I do is to run our ACS Cancer Risk 360 risk assessment, and we saw a lot more utilization and comments about prostate cancer screening after Biden was diagnosed. And, he was diagnosed at 82. Obviously a symptom detected, because he wasn't undergoing regular screening at 82. Is that part of the potential conversation around discontinuing, asymptomatic screening? I mean, do you talk about, but I'm going to be looking and I want you to tell me if you have any of these symptoms? Like, where does that,
Yeah,
because I mean, there's still a misunderstanding between symptom detected cancer and asymptomatic screening.
right, right. And I don't know Biden's screening history. I don't know if anybody knows it. I don't think it's been public. I would love to know it just to see if there's any learning to be had there. But the problem with symptoms is that if it's symptoms of BPH, which can be the symptoms of cancer, that really, if that's starting after the time of screening has ended, BPH is so common that you really, if you're going to do a PSA at 82 because they're having some urinary urgency, then boy, you better be ready for the consequences. I'm not sure I would do that. But most of those folks have had BPH symptoms at 69 to 74 or 5. And so that's when you really want to finish your evaluation by. Now, back pain, weight loss, anorexia, that's all a different ballgame. And if they're having bone pain and you're thinking, could this be prostate cancer? Then case finding, with a PSA is totally different. But even then, I have to warn men that I'm looking at that because I just want to be sure this isn't metastatic prostate cancer or whatever. But that's a whole different ball game. And you still are opening up a can of worms once you've ordered that PSA, even if it's for symptoms. But it is something to be just wary of if you're thinking of doing a workup for involuntary weight loss at 84. If you're getting the PSA, be prepared to act on it. And it may have nothing to do with their weight loss.
Yeah.
So maybe
Dr. Chapsayan, I see you nodding. You have something to add to the conversation specifically around like symptom ordering a PSA for symptoms kind of outside of that screening.
Yeah.
Yeah.
Go ahead.
Yeah, I was just going to say, we talked about this earlier this week, and Luke and I were at an ACS mediated, conference of a lot of thought leaders, and how, the idea of symptoms it really is kind of misinformation to some extent. The idea that symptoms are a sign of early prostate cancer. I don't know if my peers are gonna love me saying this, but you guys will as primary docs. As far as I'm concerned, if someone's having symptoms, urinary symptoms at age 80 or some age well beyond that screening window, I think it's perfectly reasonable to kind of pass that along to urology. Because this decision of whether to send a PSA at that age is very, very tricky. And I'm perhaps hyper conscientious of how much you all as primary docs are trying to manage in a single visit. And I think if someone's having symptoms to the extent that it's harming their quality of life, and that's a lot for you to try to manage. And this question of whether to include a PSA, from my vantage point, I think that's very reasonable to say, urology, you're up.
Yeah, I would agree. And now if you have someone with bone pain and they have a suspicious X-ray, that's a whole different ballgame. And I think that may have been what happened with Biden, because he had bone mets. And that's a different ballgame. But right, I mean, who does 80? A lot of men are going to have some urinary symptoms. So
right,
you're opening up a big can of worms there.
Right.
Okay, what about a patient and you're trying to figure out how to start the conversation about starting screening? Anything happen recently that you're like, ooh, could have done that better? Or any patients come in the last month or so that may have been a good time to start? Did they bring it up? Did you bring it up?
So I lead with, so interesting, I'll throw this out, and I don't know if you guys are aware of this. And I don't know if Epic is different. I imagine it's a healthcare system specific decision, but I don't see a prompt in my EMR to say, hey, this patient is due for prostate cancer screening, which is different than, or a conversation related to, which is different than all the other cancer screening, with the exception of lung, which happens to be there, but we're all trying to figure it out, like how to get it there, right? It's not, breast is automatic. You don't have to ask Epic or Cerner to put it there. It shows up. So I'll just say this, I'm surprised. My question, which, probably just my shorthand, is, has anyone ever had a conversation with you about prostate cancer screening? And that might be prompted a little bit because that's the way Burfus asked it, the behavioral risk factor surveillance, so if you're looking at your state level data, that's what they ask in Burfus is, have you had a conversation with a healthcare provider? So that's usually how I lead in. And it's fascinating to me, even even in patients who've had a previous PSA, the majority of people say no, they haven't had a conversation. So that, I don't know why, but to me, that seems like an easy way to get started. It's like, well, no, I haven't. I'm like, all right, well, let's have a conversation. Let's start with you telling me what you know. And so then we kind of go from there. As I mentioned before, I do feel like, often my African American and Black men are, kind of coming in with a little bit more interest and willingness, to do it. Um, Everyone asks about, do I have to have a digital rectal exam?
And I hope you say no.
I say no. That is absolutely what I turf to the urologist. No, I don't. Yeah, I'm like, nope, we don't have to do it.
Yeah, actually, I was just at a UVA. I'm on the community advisory council for UVA, and we had a lot of community leaders at this meeting, and it actually, at least locally in our African American community, the concern about the digital rectal exam is a major barrier to thinking about prostate cancer. And so we do have to kind of frame this whole thing as, this is not about a rectal exam. This is about a blood test.
Yeah.
The rectal exam might come down the line, but it's not part of this recommended screening.
We even took it off of our American Cancer Society new informed decision-making tool, because I mean our guideline says with or without, but they originally put it in there, and I was like, we need to take that out, because that is a documented barrier to patients, and so anyway, I think the tide is changing both in practice but it's so great to hear that they're, when you ask them what they know, and then that's some great relief, I'm sure, for that patient to be like, oh, okay, well, maybe I will consider this.
Yeah, and there's some enthusiasm in the chat for, like, for that. And actually, now that you say it, putting that together with the busy, overwhelmed world that is primary care and the long list of things that are going to come up for any patient, if we could do more, from the public standpoint to get the word out that it's just a blood test, then you might have more patients asking about it, right? Because in the end, I begin my patient visits with a line of like, hey, I have a bunch of things I want to talk to you about today, but I want to make sure that whatever you have on the agenda goes first, because I don't want to get the I'm on the way out the door surprise. I have chest pain, can't breathe, my feet are swelling, and here's 12 other things, and I spent the whole time talking about, the PSA test, so, but if it, do you know what I mean? Like, if it's on their agenda,
Yeah.
we do need to prioritize things, and, you can't get through everything. So, anyway, just a plug for what we can do to get that out to the public, that it's just a blood test, just a blood test.
Yeah. And FYI, Epic it could be part of a pop-up for everybody. It's just they have that capacity. I've been lobbying for it at UVA, but they have had a number of other pressing agendas, so I've never gotten it on the table. But it can be a pop-up to at least have the discussion, to offer it. And you could set the time range on that. But it hasn't happened at UVA. And I don't know if it has. It sounds like folks have entered it manually, which you can do, and I've done. But it would be nice to have it automated so that you have to at least think about it and offer it to your men. Part of the issue, again, is it's a C recommendation from the U.S. Preventive Services Task Force, and I think a lot of places are only thinking about things that are B and A recommendations from the U.S. Preventive Services Task Force. I'm not sure about that, but I think that may be an issue.
And a little more on the DRE, just from a urology perspective, absolutely agree with everything you all are saying. Like, we're seeing, DRE dropping from guidelines, even our, prostate cancer guidelines, the language has become so much softer, optional, consider, or, certainly if it's recommended, it's not until they're seeing us with an elevated PSA. And, the reality is, even though it is still part of some of our guidelines, when I talk to colleagues, it's really not being done very much. If that is any part of the hesitation for your patients to get screened, I would be, very quick to say, don't even worry about the DRE. If the urologist wants to do it when you see them, I mean, by all means, politely decline, because it's very limited in sensitivity and specificity, and we have such better tools now. I essentially pose it to an option with, pose it as an option to patients, and especially if they're going to be going ahead to an MRI, the DRE is really not adding much, if anything. And so if that is at all a deterrent for them, tell them, don't worry about it. You can politely decline it if your urologist wants to do it. And even then, most are not, is my understanding of the field right now.
I think I may have mentioned in the first session that part of the Prostate study in Germany, they did a ton of digital rectal exams on a subset of the 50-year-olds, and the detection rate of clinically significant prostate cancer was infinitesimally low.
Yeah.
And so it's just, and I'm not sure who was doing those rectal exams, but and I'm just saying whoever was doing it, it just points out that it's a terrible test. Now, it might be good in the hands of some people, but certainly from a population screening standpoint, we should not be talking about it. Or we should be saying you don't need it.
Yes.
It is just a blood test. That's important. And that blood test has ramifications, but it's just a blood test.
Okay. Mindy, take it away for our next steps.
All right. That was great discussion. Thank you so much. For those of you who are on the call, please sign up for a case presentation. You can do so simply by shooting me an email or using the QR code on the screen. Actually, I can also, since we have just a minute, share with you the link to do that, as well as a survey link. So just give me a moment while I blab here. And I will turn it over to the survey so that you have more time to do that, because it's the most important to us. Please take the survey. It's a very short, I think it's 3 to 5 questions. It takes no time at all, but it really does make an impact for this program. We want to make sure that we are providing you with the information that you need and want. So please do take it. The link is also in the chat. And then is session 3 on your calendars? I sent out calendar invitations. I'm sad by the smaller attendance today. This is such great information, and we clearly have the right people attending, which is lovely. I would also like to see more attend because I know that you are not the only ones out there that can benefit from sharing amongst each other and hearing from our experts. So please come back on December 12th. Is that right? Yes, December 12th. Same time, same place where we will learn about how to minimize harm and reduce overdiagnosis. Oh goodness, I zipped through that. Okay, and then these are the list. This is the list of echo programs that we currently have going on that are open to the public. When I send out the slides and recording, these will all be made available to you, or you can go to our website. But you are welcome to join anything that is of interest. We would love to have you participate in others. And then as Molly was speaking about, ACS Cancer Risk 360, here is the resource. And this will be in the slide deck as well as all the other resources that we went through in the last session. We will just continue to have these as a part of the slide deck so that you have them. But with that, our session is concluded, and we look forward to seeing you in December.